Hello, good morning. This is Jamie Stevens. I'm with Centris Health of Kansas City. I think we'll go ahead and get started. To give a little bit of orientation to this presentation, this is a general risk adjustment overview with a focus on cardiology and endocrinology. There'll be two parts to this presentation. The first part will be just a general overview of what risk adjustment is, why it matters, and how it impacts our current and future payment models. And then the second half is we'll take a look at specific cardiology and endocrinology specific ICD-10 codes and talk a little bit about why these codes are relevant and what some opportunities are around these high use codes. Feel free as we go along to type questions that you have in the chat. I'll be happy to stop and answer those questions as best I can as we move along. So with that, I will get started. This presentation is hosted by Centris Health. For those of you who are not familiar with Centris, I wanted to give a little bit of background on what Centris is and let you know how your healthcare organization is affiliated with Centris. Centris is a clinically integrated network, which means we have a degree of shared contracting and incentives based on our overall ability to improve health of our patients, doing so at the lowest reasonable cost. So the more we're able to generate savings and produce high quality, cost-efficient care, the better we perform under various contracts. We do this by sharing clinical information in an effort to have a more seamless care delivery model across the entire continuum of care. Centris Health is comprised of more than 1,600 physicians representing employed medical groups at North Kansas City Hospital, Advent Shawnee Mission, and the University of Kansas Health System, as well as many independent physicians, including those affiliated with Kansas City Metropolitan Physicians Association, also known as KCMPA. Currently, Centris Health has major contracts in place with Blue KC, Aetna, and Medicare through the Medicare Shared Savings ACO model. So I'm going to begin by providing a general overview of what risk adjustment, or I may refer to it as RAF as we go along. RAF stands for risk adjusted factor. I'm going to discuss what it is and why we should focus on it, as well as how our current payment models are dependent on our ability to appropriately risk adjust our patient's health status. So Medicare and other payers use various methods to determine and assign risk adjusted factor values to patients in an effort to anticipate the total cost of care that it's going to take to manage that patient throughout the year. They do this by having selected ICD-10 codes that are assigned risk-adjusted values. These RAF values are cumulative in nature and based on the number of diagnoses that the patient has. In order to determine the patient's RAF value, each year the health status of the patient must be redetermined. We do this by having healthcare providers assess, treat, and document RAF diagnosis in the patient's medical record. So when the patient comes into the office during any face-to-face visit, the provider sees that patient, makes a determination of what their past medical history is, and some of those diagnoses, especially complex chronic diagnosis, will be assigned a risk-adjusted value. The next important step of that is that billing departments must have a process to code that office visit, incorporate those diagnosis codes, and submit them through the claim to the payer to have those diagnoses received by them and then the risk-adjusted value assigned. Something we often see is that providers will spend a lot of time being very specific about the risk adjustment diagnosis that they use, but they may have other problems going on too. And when the coder gets the claim, we see sometimes that risk-adjusted codes could be left off because maybe it was perceived that other codes were a higher priority. There's some administrative limitations to that. So it's really important that it's not only a physician and a provider side to be accurate and capture appropriate codes, it's also administrative and a billing side to make sure that the codes that are high priority and carry the greatest risk adjusted value and really better reflect what's going on with that patient are captured and placed on a claim. So this model places a higher importance on documenting and coding all conditions whenever we're able to. So especially in a specialty field, if there's a complex diagnosis or very specific diagnosis that's being seen, you may not see that patient as frequently as maybe their primary care provider. So it's really important that during those specialty consult visits, we're capturing those codes, submitting it. And ideally, if it's a shared medical record, we're updating the problem list so that it's there for the provider to see. And if they include that in their medical decision making as they see patients throughout the year, they're able to incorporate that into their chart as well. If the medical record isn't shared, so say it's a Advent specialist who shares the same chart as a primary care provider, that makes it a lot easier to have that common chart. If it's a specialist that's outside of the network, so maybe it's an independent primary care provider referring to a hospital system specialist, being as specific as you can with the assessment and the diagnosis that's assigned, that goes back to the primary care provider so that they're able to then take that diagnosis and incorporate it into the record in a way that's very specific. These diagnosis codes are then used to generate what's the expected cost of care for each patient. Generally speaking, a RAF value that's higher, or the higher the RAF value, the greater the anticipated cost of care for the patient, and that creates a more likely scenario where we could be competitive under a shared savings arrangement. So this next slide will show a couple scenarios on how risk adjustment impacts the determination of how much it's expected to cost to take care of patients with various health conditions. So what we see here is 3 different boxes representing different coding practices on the same patient. So in this example, the patient is a 76-year-old female. She has a past medical history of depression, cardiomyopathy, COPD, depression, and morbid obesity. So Medicare assigns a RAF value for age and gender. So you'll see at the top line that this is a 76-year-old female, and the age and gender demographic value that's assigned to this patient is a 0.452. And that's the same across all of these patients. This model also assumes that the average health of an average health person would be assigned a risk-adjusted value of a 1.0. So if your average health compared to everybody else of your same age and gender, a risk-adjusted average score would be a 1. And if you were a 1, it's anticipated that the total cost of care per month for that patient would be $700. So if you look at the red box on the right, it shows what happens when no risk-adjusted diagnoses are captured. So maybe this patient wasn't seen in a calendar year by a primary care provider or by a specialist who would code this visit, or maybe they just came in for an acute visit, maybe a sinus infection. That was all that they were taking care of, and none of these codes were used. If that was the case, the patient's RAF score would be purely based on their age and gender. So in this scenario, the anticipated cost of care per month for this patient would be $316. This includes any coverage for expenses related to inpatient or outpatient services. If they have an ER or a hospitalization, that would be the extent of what we're required to manage this patient on. Given what we know about the complications of this patient, it'd be really difficult to manage year to year this patient with a budget of only $316. So if you look at the yellow box, it shows what happens when some of the diagnoses are captured. The RAF increases to $736, which is slightly above average. And you'll note that the depression was captured, but this was a code that's a non-specific code within the depression category. So although the depression code was captured, it was captured in a way that didn't accurately reflect what was going on. So no risk-adjusted value was added. If this provider would have coded the patient as major depressive disorder, single episode in remission or mild, it would assign a risk-adjusted value, but since that wasn't done, it's a 0. The provider captured the cardiomyopathy. Even though it's unspecified, in this case, it does give credit, so that added a 0.337 to this patient's RAF score. The COPD was not coded, but the morbid obesity was coded, which adds an extra 0.262. So this increased the patient's overall risk-adjusted score from a 0.452, which was just demographic, up to a 1.051, which is just above average, and the annual or the per member per month benchmark for cost is slightly above average, also at $736. So if you look at the green box on the left, you'll see all the diagnoses that we know about this patient have been captured, and the budget for the patient was increased to $1,313. You'll see the appropriate depression code was used, which added a 0.353 to the score. The COPD was captured, which wasn't in the previous scenarios. And you'll also notice that since COPD was captured, along with the cardiomyopathy, this risk adjustment model provides additional RAF credit when there's a complex disease interaction. So because the patient has congestive heart failure and COPD, it added an extra 0.19 to the risk adjusted score. So when you look at how these different coding practices impact the anticipated cost of care, the monthly budget for this patient increased by almost $1,000 a month from the red to the green scenarios, which is equal to a change of about managing this patient at about $3,800 a year to almost $12,000 per year. So managing a patient with an anticipated cost of $12,000 a year is clearly more realistic than trying to manage a patient with less than $4,000 in terms of trying to create opportunities for shared savings. So if a patient is hospitalized or they have frequent specialty appointments or imaging is required, diagnostic testing, it makes it much more realistic to manage the patient at these costs. As I mentioned on the previous score, some diagnosis categories, when found together on the same patient, are awarded additional RAF credit. So this table shows groupings that provide additional RAF weight when found together on the same patient. For example, if a patient has an immune disorder and cancer, they're given an additional RAF weight of a 0.892, which is a very high additional score. Just it takes appreciation for the complexity of those two conditions happening together on the same patient. For the interest of this is a cardiology focus. You'll see congestive heart failure is a main theme with the additional RAS credit for the disease interaction. So if a patient has CHF and COPD, diabetes, or renal issues, they're awarded somewhere between a 0.182 and a 0.27 in additional RAF credit. So it's really important that if you're evaluating a patient, you know that they have comorbid conditions, especially if they're in this grouping category, that at least once per year these codes are captured and reported. Nothing special has to happen by linking them or anything like that. It's just they need to be present at some point during the year. All right, so we're going to shift to looking at some specific codes for cardiology and highlight some things that we see. A lot of this data, and you'll see tables at the bottom, are based off of Centris going through all the claims data that we receive from Medicare, from Blue Cross, and kind of make some assumptions about what we know about our patient population, and then how do we connect that to trending, to coding trends, and things that we see across different practices within Centris. So the remaining slides will most be looking at common groups of diagnosis code. The first we'll look at cardiology, and then we'll look at the endocrinology codes. We'll cover some pointers on what to look for when coding these patients, and also provide the information to show what the risk-adjusted score or weight is for each of the diagnosis groups. So these first codes are related to vascular disease. Arteriosclerosis of the aorta is a commonly found disease in this community, and however, we found that it's very likely underrepresented in our population. A lot of times we'll see variations across providers. This goes for primary care and cardiology on how often this is found. So this is a very common diagnosis. It carries a risk-adjusted weight of a 0.31. And it's really, anytime we encourage providers to look, anytime there's a chest x-ray or a lumbar or CT chest, it's often highlighted by the radiologist, or is easily visible. So whenever possible, capturing that, and then providing some documentation in the chart, even if it isn't the primary reason why you're seeing this patient. If you indicate the location and then any kind of clinical significance or any kind of surveillance or treatment follow-up or impact on your medical decision-making, if you include that, it's appropriate to include this code and get some additional risk-adjusted credit. A 0.31 is a significant increase. It's the equivalent of having a diabetic patient that's uncontrolled. All right, so this next slide is angina and ischemic heart disease. So when selecting this code from this category, your documentation should include the type any associated spasm, any associated symptoms. And this has a combination of codes that are bundled together. So it's two different categories. If you look at the tables below, you'll see the HCC 88 is worth a 0.14, and then the HCC 87 is a 0.22. So these HCC groups represent different groupings of codes that are cumulative in nature. So if I was to have two diagnoses from the HCC 88 category, I would only get the 0.14 one time for that. But if I had a patient with a diagnosis from the HCC 88 category and another diagnosis from HCC 87, I'd receive the 0.22 plus the additional 0.14 because these are different diagnoses in different categories. So whenever coding patients with ischemic heart disease, angina, it's really important to look for those coded specifically so that that patient's risk profile will have that cumulative credit applied to it. So this next slide is related to ischemic and unspecified strokes. So we're going to look at the CVA codes because at times we find by looking at the data that they may be improperly used. So the CVA code should only be used for acute episodes. Once the patient is discharged from the hospital or wherever they were made that diagnosis, they no longer have this acute CVA code that's used. It's risk adjusted at a 0.258, and it's really for just that single episode when it happens. After the patient is discharged, the correct way to document this is history of CVA. All these patients are really complex and difficult to manage and need close attention. The past history of CVA is not a risk-adjusted code. The code ranges for acute CVAs are those I-63 and I-66 codes that are shown on the chart there. So this next line looks at hemiplegia and hemiparesis. So even though the risk adjustment code for past history CVAs isn't risk adjusted, if there's ongoing effects as a result of that episode, there is a way to risk adjust that. So the category with the I-69 set of codes contains codes related to the sequela of the cerebral vascular disease. So this is the residual remaining effects of an acute phase of the illness, which has since passed and now it's a past episode. We oftentimes see providers coding it as muscle weakness generalized, which is M62.81. And this is a less specific code. It may not accurately reflect the consequence of that CVA, and it does not have a risk-adjusted weight. If no residual effects exist, you can use the code Z86.73. We see this often. That's the appropriate way to code a patient with no residual effects. And even though that's the appropriate way, there's no risk-adjusted weight, which is fine, but it's the proper way to document it. If the patient does have ongoing effects like a hemiplegia, hemiparesis, you can use the set of codes below. So the I-69, two top codes affecting the left or right, or the G81 codes that are shown at the bottom. And it doesn't have to be a complete paralysis. It can be a partial, it could be a weaknessing, but as long as it's related to the cerebral infarction, it's fair to use those codes as long as it's supported by documentation. And it's best to reference the originating event as well. If there's any questions, feel free to ask them in the chat box. You can send them directly to me or give it to everybody, and I will take breaks as we go to fill this in. So this next slide has to do with cardiorespiratory failure. So many patients with severe standing COPD also have respiratory failure. Typically, patients with chronic respiratory failure require supplemental home oxygen therapy. So the diagnosis could be considered for any patient that is using home oxygen. We often see that there's a code Z99.82, which is dependence on supplemental oxygen, is commonly used, although it's a generic code, and this also does not have any risk-adjusted value. So if you see on the table at the bottom, if you use the J96.2, 0.1, 0.01 codes, you could code this as an acute chronic respiratory failure with hypoxia. These codes are risk adjusted at a 0.282, and would add to that cumulative risk-adjusted value. So if you have a patient that comes in on oxygen, or you know that they're being managed with oxygen at home, it's certainly an opportunity where you can consider those codes for use. The next slide is on arrhythmias. I'm not going to spend too much time on this just because cardiologists catch this code all the time, and I think they're pretty good with capturing this whenever they're treating a patient for that. A couple things I'll point out. It's worth a RAF value of 0.269. Even unspecified atrial fib and atrial flutter codes are risk adjusted. Certainly, the more specific you can be, the more helpful it is for your coding staff, and I'm sure they would appreciate that. This is the other reason I bring this up is this may be something you see a patient for. If you send it back to the primary care provider with a specific code that they can incorporate on their problem list or update it on your shared record, that's helpful. And the other important thing to note is even if a patient isn't actively experiencing atrial fib symptoms, it's still reasonable to code that patient as long as you document that it's stable, being managed. If it was permanently repaired with ablation or some intervention, then it would move to not an ongoing chronic problem unless there's still issues with that. But if it's a managed atrial fib or just episodic and it's just being monitored, it's still fair to code this as a chronic or persistent atrial fib. All right, I think we're going to move over with the following slides to more endocrinology related diagnosis codes. So the first two slides are going to talk about diabetes, and diabetes is when we look across all the codes that are submitted through Centris across all these payer groups, diabetes is most commonly captured risk-adjusted diagnosis by Centris provider. Risk-adjusted weight for diabetes is higher for patients with complications than it is if they're well controlled. And data shows that we're often finding that we're coding patients as having diabetes without complications when it's highly likely that they actually do have complications. So if a patient is diagnosed with diabetes without complication, the risk-adjusted weight assigned to that patient is a 0.106. If the patient in fact has complications and we code that and capture it and document appropriately, that goes up to almost 3 times higher at a 0.307. So it's really an important area to capture the nuances between complications and non-complications. This next slide shows the most common diabetes codes with complications. When we look at this from an endocrinology or a specialist point of view, endocrinologists do an excellent job in general of capturing the appropriate level of service and type of complications. We see, oftentimes we'll see primary care providers that just code diabetes without complications on almost virtually all of their diabetic patients. So I'm sure they're managing their complications and doing a good job of taking care of the patient, but their documentation and submission of codes really don't reflect what's going on with those patients. So this is the most common complications that we see. As I mentioned before, these are all part of the HCC category. So even if a patient has 3 or 4 of these different complications, which is something we commonly see, they still only receive the 0.307 risk adjustment. So if a patient has hypoglycemia, neuropathy, and CKD, all of those are 0.307 risk adjusted, but since they're in the same category, they only receive that risk adjusted credit one time for the 0.307. So this next slide shows some commonly overlooked endocrinology codes that are missed by primary care providers, but are most often captured by endocrinologists. So all of the codes on here show a RAF weight of 0.193. These are things that are probably commonly seen in your practice in some degree if you're an endocrinologist or coding for an endocrinologist. If a patient is just going to an endocrinologist and being diagnosed and is not seen with great frequency, kind of like what I talked about before, it really is helpful to get a specific diagnosis sent back to the primary care provider, updating the problem list, and being as specific as possible so that this is captured on an annual basis, especially if it's a patient you're likely not to see back anytime soon, that hopefully can be perpetuated at a different level of service. So CKD is the next slide that we're going to look at. So CKD is assigned a RAF weight depending on the stage of the disease, with lesser weight given at stage 3 and higher weights given at stage 4 and 5. So previously, up before I think 2019, CKD stage 3 did not have a risk-adjusted weight assigned to it. But recently they added 0.07. So it's not a lot. It's probably the lowest amount of risk-adjusted weight that is available to any code. But starting at CKD stage 3, that weight is determined. If you're seeing a patient with diabetes and CKD, I think I'll go back to the previous slide. So the E11.22, diabetes with chronic kidney disease, you need to add that additional code to show what stage of CKD the patient has. So if you're coding diabetes with CKD and the patient has stage 4, you would code the additional N18.4 to receive the additional risk-adjusted rate for that patient at a 0.288. It's also important to code the higher levels of CKD as early as we can when it's been determined that the patient has severe CKD. There's certain programs that your system probably participates, like CPC Plus or the Medicare Shared Savings ACO, that treats patients with ESRD differently than they would treat the rest of the population. So since those patients are very expensive to manage if they're on dialysis and receiving ongoing care, the sooner we're able to identify those as ESRD patients, the sooner they're moved into that separate category, and we have more opportunity to appropriately manage them at an appropriate cost. So this is the last slide that we're going to look at, having to do with specific diagnosis. So this is morbid obesity. We certainly have patients that meet this category that come into our practices. So morbid obesity is defined as having a BMI of 40 or greater. There's also another caveat that if a patient has a BMI equal to or greater than 35, they can also be coded as morbid obese if they have a additional comorbid chronic condition. So the comorbidity and the morbid obesity really should be submitted on the same claim in order to capture that HCC credit. So an example would be that if a patient has a BMI of, say, 36, they fall under that morbid obesity of 40, but they also have hypertension or they also have diabetes. If you code those together, that patient would qualify as being morbidly obese. If you look at the table below, you'll see the code for morbid obesity is E66.01. That's a risk-adjusted weight of 0.262. Oftentimes systems just at a coding level will pick up these Z codes, which stage, it tells the payer what range the patient's BMI is. So if you just coded a Z68.41, it would show, oh, this patient has a BMI somewhere between 40 and 45. They're morbidly obese by the clinical definition and receive that 0.262 risk-adjusted value. But if a patient has a comorbid condition, so say you're seeing them for diabetes, they don't have a risk-adjusted score of a 40, it's 37. There is a Z code to report that 37 range, but if that Z code is reported and the diabetes, it won't calculate out to show morbid obesity. You need to, in that instance, use the E66.01 plus the diabetes in order to capture that additional morbid obesity risk adjusted credit. All right, so this next slide shows a table that has some different ideas around how to support your documentation for risk adjustment. So the intention of this session isn't to come to direct you how to code your visits or how to properly document that. It's really just to raise awareness of how the risk adjusted model works and provide some guidance and knowledge around what our data tells us about the prevalence of various codes in our system. And the reason we do that is each of your systems or organizations or clinics really probably have some kind of standards in place that guide you on how to appropriately document and ensure that you have the right level of documentation within your chart. It's not our position to dictate how that goes. I'm sure you have very robust systems internally on what coding standards are, how to meet them, and how to support the codes that are on there. So this table shows some examples of what elements should be included in your note in order to provide documentation to support the use of the code. So in risk adjustment, when they're looking at review, the acronym of MEET is commonly used. And MEET is just a simple way to provide the right types of elements in your note to support the RAF coding. So MEET stands for monitor, evaluate, assess, and treat. For example, if you have a patient that has diabetes, you would monitor by stating whether the diabetes was stable. If the patient is testing at home, you could use evaluate by citing how the blood sugars are running. You could assess the patient by providing counseling or maybe reviewing records that come to you from the primary care provider or other specialists if they've been consulted. And you can treat by prescribing medication, making medication adjustments, or if you make a referral for additional testing or imaging or consults with other providers. So you don't need a ton of documentation, and I can certainly appreciate that the physicians are not coding experts, and we shouldn't overburden them with unnecessary documentation. So just coming up with quick, easy ways to indicate what is being done to manage that diagnosis really supports risk adjustment efforts and having the right type of documentation on the claim. So here's a general overview of some things to help with risk adjustment. So I've mentioned this a couple times. I really believe that if we're going to have a good, consistent risk adjustment effort, it really all starts with having a problem list that's up to date and is as specific as possible. So recommendations on this is involving staff to maintain risk adjustment or problem lists, make sure they're accurate. If a patient's labs come back and they indicate a A1C that's out of range, or a lab that indicates that the patient has a certain stage of CKD, making sure that not only are we reviewing the lab and doing that, but updating the problem list to reflect what's happening with that patient and how their disease is progressing. So involving staff and also, clinical staff, your nursing staff, scribe staff, and then updating it and reviewing it with the provider as needed. Some systems in clinics go to a pre-chart audit. So maybe at the beginning of the day, they'll look at the patients that are coming in, make sure the chart and the problem list is up to date. Some systems have flags in place that call out codes that haven't yet to be captured in the calendar year, or if a patient's due for testing that may help determine the stage of a disease, really working those up. Reviewing prior records and prior notes from specialists and seeing if there's diagnosis that weren't fully incorporated into the chart. And many health plans provide information about patients. So if you see a patient's past due for services, or if there's a diagnosis that they've had at an outside facility that we didn't know about, sometimes we'll get reports back that incorporate those. And really the next most effective way is really having a team-based approach for risk adjustment. So discussing risk adjusting coding regularly with the providers, the clinical staff, and involving the coder in on those discussions. So maybe on a quarterly basis or whatever frequency you think would be appropriate. Getting that team of people together, especially if you have a coder that primarily works with you or the provider or small group of providers. The coders are really have good knowledge about what that doctor's trends are. They probably have opinions on what they can do in the chart to better support the code that they're submitting. And they may be able to even give points on, hey, you're way over documenting what we need. Here's the standards that we need to meet. Any documentation you want to add is great, but providing some education around what the threshold is, and if providers are spending unreasonable amounts of time document for coding, there may be ways to streamline that and make it more efficient. So just in conclusion, risk adjustment is really important. I see this as one of the most important ways that health systems are able to be viable and perform well under future payment models, and even perform under current contracts that we have. I've given you a small number of codes to look at. There's certainly many other within your specialty. If this is newer to you and you want to kind of learn, I would recommend taking 3 or 4 codes within your specialty that you think that you could probably be more specific with and have an impact on risk adjustment. Work with your team on that. Once you've got those down, kind of adopting 3 or 4 new codes. There's tens of thousands of risk adjusted codes, and it's not really reasonable that people can be on it all the time with that. But making small incremental changes is really helpful. I think it's important to emphasize that documentation of these codes are critical. We don't want to be in a situation where we're using diagnosis codes that aren't appropriately supported and managed at the in terms of documentation and supporting reasoning for why we're making that documentation and submitting it. Problem list management and team approach to capturing these risk adjustment codes is certainly helpful. This shouldn't be just a physician problem. It's something that the clinical staff and coders can certainly participate. And again, just providing documentation standards that are outlined by your organization to support any kind of risk adjustment code is always recommended. And with that, that concludes my presentation. If there's any questions, I'm certainly happy to answer those. Okay, seeing none, I will conclude this presentation. These slides will be made available to people after the presentation. There's a brief survey at the end of the presentation. If you would take 20 seconds to answer that, I'd certainly appreciate it. Well, thank you again for joining, and I wish everybody has a great day. Thank you.